proceed without paying tribute to Veno-Lymphatic World International Network, the Veint Foundation, with the 3 stars, Professor Sergio Giannassini, Professor Oscar Bottini, and Professor Willy Kai, who all played a key role in the success of this educational event. I would like to thank the professionals in both continents, Latin America and Africa, and really in every corner of the world who dedicated their time and expertise to participate and enrich this event. Today's theme is foam sclerotherapy, a topic that's very important to all of us. The speakers are Dr. Juan Chunga and Dr. Carlos Simkin. Both have wide experience in this technique. We are also delighted to listen to tips from the Grandmaster of foam sclerotherapy, Lorenzo Tesari. It's my pleasure to introduce our esteemed panelists who will be presented in person later in the session. I'm also delighted to introduce our guest of honor from Egypt, Professor Issam El-Qadi, and our honorary chairperson from Latin America, Professor Hugo Navas. I would like to remind you of our award for the best question, which is $500 towards flight expenses plus free registration for the Winter Conference, which will be held in January 2022 in Dubai. There is a panel of 10 international figures which will decide which is the best question. I would like to thank our sponsors, Servier d'Aflon, Medtronic, Biolytic, ECS, Medi, and ProMed for their educational grant, without which this would have not been possible. Now I would like to present our first speaker, Dr. Juan Chunga Prieto. Dr. Juan is Secretary of the Peru Society of Phlebology and Nephrology. He's member of the Engagement Working Group of the IUP. He's also a member of the American College of Phlebology, of the Mexican Academy of Phlebology, and of the Pan American Society of Phlebology. We'll enjoy listening to your presentation, Dr. Juan Chunga. Please go ahead. Share your screen.
Thank you very much, Professor Bishara. I will just share my screen. Is it good?
Very good.
Well, first of all, I would like to thank the organizers of this event, especially Professor Bishara, Professor Wasil Ataja, and Sergio for giving me this opportunity to participate in this important event. Sclerotherapy is an operator-dependent technique. That is why the only way to master it is by treating as many patients as you can. We get a chance to do many medical campaigns all over my country. So as we help people, we become better at it. Also, we have trained many physicians from many parts of Latin America. As a second-generation phlebologist, I have inherited the experience of over 30 years of practice from my father and have personally treated thousands of patients with successful results. I've come today to share my expertise on this field, bringing you specific technical tips to use in your everyday practice. We all know that the best results come from a good doctor-patient relationship. That's why for us, it's a must that the patients know how sclerotherapy works, that they are part of the treatment and what to expect from it. We explain the patients how the vein is going to get closed, what medication we are using with them. We perform the treatment once a week, and in every visit, we use from 3 to 6 ml of foam. In special cases, we can do it faster, like every other day, and up to 12 ml per visit. We offer a detailed explanation of the procedure and its results. And if possible, we include a photographic record, especially because sometimes when you are doing aesthetics, the treatment, the patient don't remember how they look prior to treatment. And the most important thing is to include all necessary information and possible complication in the patient's informed consent. Some general considerations prior to treatment. Have all your materials at hand. needles of different calibers, a syringe that will hold the foam. You have to try all the syringes in your market and find which one hold the foam for the most time. Have an emergency kit just in case. I have never used my emergency kit, but I always have it with me. Find a comfortable position for you and your patient to inject. That I will explain later. And treat according to the stage of varicose disease and the kind of varicose vein that you find in your patient. And this is what we'll be discussing next. When treating telangiectasias, the most important issue is inflammation. That is why you must treat them gently. As you can see in the video, sometimes this is bigger than the telangiectasia itself. Then, when we are in, we slightly pull up the skin because that's where you get in the telangiectasia and put the foam. Inject as slow as possible and don't get excited. This means that you don't want to make all disappear at once. Sometimes when you're putting the foam, you see all of them disappear and you keep going and keep going. That's a no-no for us. The secret to precision is this. We use our pinky as a stabilizer for the rest of the hand. So even if the patient moves, the needle will remain inside the vessel and we can inject the medication. Another trick is to start in the darker points. Someone called them the blackheads. When you put the foam, you apply direct pressure in the area to reduce inflammation. If exacerbation occurs, press it to remove the medication and don't continue to do the treatment in the same area. And if the patient expresses some sharp pain, stop injecting immediately and apply cold. Most of the skin necrosis cases appear after treating telangiectasias. So even if you are careful, you must tell your patients what can happen, because the sooner they contact you, the better result you'll get. When treating reticular varicose veins and even medium varicose veins, most of the patients don't know these are varicose veins. They tell to me, no, they are my veins that see through my skin, and that's a no-no. So we have to teach them and even show them, because sometimes they don't see where the sclerosing agent goes. You see that where it starts, but then it diffuses on all the reticular veins. And when you have a patient with a lot of reticular veins, ask where is the most troubling area for them. Where is hurt the most, where is the pain starts, where it itches the most. Patients, and if you start the treatment there and you eliminate the reticular vein, the patients come to their second visit amazed, because in our experience, 98% of the time, their symptoms disappear or at least decrease in a big amount. Then when treating thick varicose veins or large varicose veins, we use high concentrations, 4% and even higher of hydroxychloroquine. In Peru and some other places in Latin America, we use some local made polylocanol, so we can get even higher concentrations than the ones the industry provides us. And that gives us outstanding results. We use bigger needles sometimes, as you can see in the video, and the effect is immediate. Another important aspect is that you must have the vein as bloodless as possible to avoid the appearance of the sclerothrombus. So we can do with the patient lying down, or we can do the treatment with the leg elevated. And after the treatment, the patient must rest for at least 20 to 30 minutes with the leg elevated. You don't need to see the whole vein is full with the sclerosing. That's what when we do it with ultrasound view. We use the 2-point technique that you are seeing in the video, which consists in applying the sclerosant in the most prominent places. And thus, we achieve the closure. You can start proximal or distal depending on the caliber of the vein. When we do the exam, we touch the vein, and if it's too thick, we start from the distal areas and then go to the proximal areas. And also, if we add additional compression, local compression, it will get a better result. In the treatment of venous ulcer, most of the time, we prefer to start the treatment in the perforators that are near the ulcer. This helps the ulcer to relieve its symptoms earlier and get better faster. But if the skin around the ulcer is badly damaged, look for a long reflux and start the treatment in that area. This, plus the use of compression, will improve the peri-ulcerous skin for the second visit and the next visit, and then you can do the treatment of the perforators that are the peri-ulcer space. Some of the most common complications that we have are, the first one is the skin necrosis. The cost is caused by the entrance of the sclerosing agent to the arteriolar site. Note for extravasation. A patient will present pain or palings in the area while injecting. If you think this could happen, at that very moment, you can put ice in the area of the injection while the patient rests. Then explain the warning signs to your patient, that he or she could have burning sensation, sharp pain, and a purple coloration that you see in the pictures. If that's the case, you can use systemic corticosteroids. We use prednisone, local ice, and sometimes, if needed, analgesia. When the patient comes to your visit, if you see these kind of lesions, we apply a sublesional injection of corticosteroid plus anesthetic agent. Then we treat the wound as an arterial ulcer. You must promote angiogenesis. Thus, we use pentoxifillin. And also, a good patient-doctor relationship is mandatory because this will take a long time to close, sometimes even more than 1 month. And also, there will be a scar in the patient leg. And the other common complication is visual disturbances, dry cough, chest tightness. I have put them together because there are various causes for them. Sometimes it is a psychological component. A patient that has fainted during the injection. I don't finish to put the complete injection and they fainted. In other cases, this has happened in the 3rd or 4th visit of the patient. And sometimes this happens when the patient is getting up and getting out of our clinic. I have summarized this in 2 scenarios. The first one is when they appear when the patient is lying down. We provide time to the patient explaining what has happened. We tell the patient that this is kind of an allergic reaction and that they are more sensitive to the treatment. After a moment, the symptoms fade away. We help the patient slowly sit down and then stand up and walk inside the clinic so they go out with no symptoms. And the second scenario is while the patient is getting up. So they feel the dizziness or the visual disturbances or the chest tightness. So we allow him to sit for a moment, do some respiration exercise, and then when they feel better, do an assisted walk. Leave the office, they will leave the office without symptoms. But if the symptoms persist, we give the patient an antihistamine drug, like cetirizine. But sometimes we think it's more of a placebo effect, because when the patient has this in the first visit, when they come to the visit, we give them this antihistamine before the treatment, and this never happened again. The symptoms never appear again. Some final considerations is that, first of all, there are no limitations for sclerotherapy. If you master the technique, there is no problem for you. The best position for sclerotherapy is the one where doctor and patient are comfortable. In our experience, most of the time we do the treatment with the patient sitting down. It's better for them, we can move them side to side, and it's better for our backs also. Don't be afraid of use high concentrations. We have never had the appearance of this complication with high concentrations. Most of the time is when we are doing telangiectasia taser treatment because we do it in many places. If the treatment goal is not achieved, meaning the closure of the vein, first increase the sclerosant concentration and then increase the volume. We have applied up to 6 ml for one for the closure of one large or small saphenous vein. And compression has scientifically proven to improve the outcome of sclerotherapy. We use compression. We and our patients are good with this because we showed them that this is a good part of the treatment. This is the first time I gave this conference. It was natural to me after many years of work alongside my father, that some of you know. Watching him cure his patients was my best motivation to follow in his footsteps. So I am grateful and will always be in debt with you for letting me show our work. Also, I'd like to invite all of you to visit our practice in Peru. It will be our pleasure. Thank you very much.
Thank you, Dr. Juan. We really appreciate you sharing your experience with us, and we realize that this experience is also 30 years experience inherited from Professor Roberto Simkin, so we really appreciate this. Now I'd like to give the mic to Dr. Wasila, who is our secretary, the foundation secretary, who will present the esteemed panelists. Please go ahead, Dr. Wasila.
I wish to welcome everybody in our 5th night of Saturday Night Veint Talks, and now I'm truly honored to introduce Professor Victor Canata. Professor Victor Canata from Paraguay, and he doesn't need any introduction. In the past president of the Paraguayan Society of Vein and Lymph, professor of surgery and anatomy, and vice president of the Pan-American Society of Vein and Lymph, vice president of the UIP, and offshore he is the grandmaster of Clack's technique. Professor Canata, we are truly honored having you among us this night. And the podium is yours now, Professor Canata.
Okay, thank you very much. I'm more than happy to be here with all of you. I think the meeting was excellent. And also, my friend was give us a great lecture. From my point of view, I think there are some points that we can clear, and also there are points that we have to just address just a little bit better. But I think Dr. Chunga was showing the expertise that we are doing in all Pan American, and we are working very nice trying to just share that expertise to all of us. I have a question to Dr. Chunga regarding about the antihistaminic agent. Dr. Chunga, can you ask us what is the dosage of the antihistaminic agent, and for how many times that you can give that to our patient? And you give an excellent presentation. Thanks, Dr. Chunga.
Okay, thank you, Professor. Well, when the patient get the symptoms, like the visual disturbances, the chest tightness, we give the 10 milligram cetirizine with a glass of water. They take the pill, drink the water, and in a few minutes, 5 to 10 minutes, they get better. We use this only in the clinic. Then the patient go out and they never have the symptoms again. So it's just once. But if the patients, we have proven that this is because of the treatment, then every time the patient comes to receive the treatment, like every week or every 2 weeks, we give it prior to the treatment, and the patient does not present the symptoms again.
Thank you, Dr. Chunga. It was a really excellent presentation, and thank you very much to just leading us from South America to the whole world. Thanks to Asila and thanks Dr. Rashad Bichara to letting me just and inviting me for this excellent meeting.
It's a great honor, Professor Canata.
Okay, we can go through. Thank you very much, and let's keep sharing expertise. Bye-bye.
Bye-bye, Dr. Canata. Bye-bye. Is the Professor Malay Patel is on board now among the panelists?
Yes.
Okay, yes. Okay. Welcome, welcome, Professor Patel. Professor Malay Patel.
Everybody.
Good evening. Good evening, Malay. Thank you for joining us, Malay. It doesn't need any introduction. He's the big icon in the phlebology field all over the world. He is well known. He is settled in Ahmedabad. and in India, past president of the Vascular Society of India and founding and president of the famous Distinguished Society, the Venous Association of India. He is previously vice president and currently the assistant general secretary of the UIP. He is also a reviewer for so many distinguished journals. Professor Patel, the podium is yours now.
We can't hear you, Malay. Could you please write your question and we'll read it for you. So, Professor Sergio Giannassini, would you like to address a question to the speaker?
Yeah, Joan, excellent presentation. Historical to have you here in Africa today. So this is COVID time, and our patients are extremely frightened by the concept of thrombosis and sclerotherapy, superficial thrombophlebitis. They are, for example, a relative contraindications in Italy, but I think they are a good example of the difference between sclerosis and thrombosis. So we actually perform foam sclerotherapy when we have a peripheral superficial thrombosis of a tributary to transform a thrombotic process into a sclerotic process. What is your vision in this? Of course, this is out of the guidelines, so it's food for thoughts.
Yeah, thank you, Sergio. Thank you for having me here. Well, yes, there are some cases, a lot of cases of thrombosis in COVID times. But when we do the superficial treatment, we have no problem. Like I told you a long time ago in private, we started our practice in July. We have received over 60 patients in the first month. We don't have any problem with thrombotic. We have in the informed consent tell the patient some alarm signs to tell us if they feel some discomfort, just to do some antithrombotic treatment. So we don't have problem. And also when we are doing some large saphenous vein or small saphenous vein, I have, for real, I don't have any special treatment for these signs, because as you say, the sclerothrombus is really different from the thrombosis that could happen for COVID, because it's the sclerosing agent trapped by the blood, as Dr. Parsi showed in his in vitro experiments. So in our practice, we haven't have a special differentiation for this. Just tell the patient the problems that they can present to visit as soon as possible. But we don't have any special treatment.
Thank you so much.
Okay, thank you, Juan. And now we have a question from Professor Malay. He sent it to my phone to you, Dr. Shunga. What is the experience with the use of physiological gases and ultrasound in improving safety? And we have in the question and answer box also the same question about the CO2. Maybe we can combine both questions together later on. Thank you, Juan. And just a small question. Did you request the D-dimer before your foam sclerotherapy during COVID time?
Okay, yes, no, as I just said, no, we haven't had any special treatment just for the sclerotherapy treatment. And okay, as the patient visit us every week, we are following them, and there are no signs of thrombosis yet. Right. We use room air. I've never had experience with CO2 or just O. We use room air. Even when we are doing sea level water, and even in the highlands, we don't have any problem with using room air. And well, ultrasound, we really use this very few times, just when we are doing some large saphenous vein, not when we're doing the superficial. Most of the times, if needed, I use the other light. How do you say I forget the name of this. Transluminator. Sorry. Okay.
So we'll shift to the third panelist, Dr. Rashad.
Yes, please.
Now, truly honored to introduce Professor Askhad Sharipov from Kazakhstan. Professor Sharipov is the Executive Vice President of Kazakh Society of Phlebology, head and owner of Phlebology Center of Phlebomed, and for 2 consecutive years, he did run outstanding Venus Forum in Almaty, and it was really a top-notch scientific conference. We are truly honored having you, Askhad, on our day of FOAM. Askhad, the podium is yours now.
Hello, everybody again. Really nice to see all my friends and colleagues in good health. Thank you, Professor Rashad and Professor Vasila for invitation for me. And Dr. Chunga, thank you very much for your excellent presentation and your comprehensive, brilliant experience. My question is about your personal experience regarding post-procedural compression. What kind of compression do you use after sclerotherapy for varicose veins and radicular veins, respectively? And how long do you use compression after sclerotherapy? Thank you.
Thank you, sir, for your question. It's an honor. And it's from a long time ago, even before there was a stocking, we use the simple bandage, elastic bandage, of the elastic bandage, and we teach the patient how to do it. We have we train the patient, we give them videos, we give them a practice in our clinic how to put the compression compression bandage. In most of the patients, we do it during, when we do the treatment, it's 24 hours, the compression. But then they must use it during the whole treatment. So as I say before, we do the treatment every week. Sometimes a leg is 1 month. They use the compression for 1 month, the treatment. They only take it out at night when sleeping and when they're taking a shower. Then they can go to work, they can do exercise, they do the everyday chores with the bandage put on. In telangiectasias and reticular veins, when the patient don't have very big veins, we can change it for stockings. But most of the time we start with the bandages, the 6-inch bandage.
Okay, thank you very much.
May I ask Professor Sergio Giannassini to introduce Professor Fedor, please?
Yes, and I will do that quoting a paper from Phlebology 2009, Venous Hemodynamics, What We Know and What We Don't Know, whose author is indeed Professor Luri, because we know that introducing him is like introducing Beethoven, so no needs of introduction. What we don't know is that you have, of course, to know him personally. He's also a wonderful person. When you have the chance, get close to him and know him also as a person, not just as a huge professional, as we know from the literature. Fedor?
Thank you, Sergio, for the very nice introduction, and thank you all for the honor to be here at this wonderful meeting. There are very many good questions I see on the screen, and a couple of them I would like to combine for you, Dr. Changa, is are you at all concerned about either current or history of DVT? What do you do anything different in patients who have a history of DVT and post-thrombotic disease?
Okay, yeah, if the patient have a history of DVT, we start the treatment very in superficial veins, and we only, in the first treatment, the first visit, we only put up to 3 ml of foam. This is how we are checking the patient through the whole week to the next visit. If there is no problem with that, we can continue the treatment. But we only put one syringe of 3 ml of foam, and the compression, as I explained earlier, is mandatory during the whole treatment.
Go ahead, Professor Lurie, if you wish to select another question, please.
No, absolutely. Thank you very much. That's an excellent answer. The other couple of questions here are regarding the small veins, and this one is where you treat the very small telangiectasias. Do you still use foam, or you switch to liquid sclerosant? And then do you use any different needles or syringes? You partially addressed it, but people still asking to comment.
Okay, when treating telangiectasias, the first time we use foam, but big bubbles, foam. We do the treatment because the secret is to do it gently, very gently, the injection. But if we see that there is a redness in the area, the next time we can change it to liquid. About the needles, most of the time I use the 27 French needle, but when doing telangiectasias, I can use up to 30 French needle to canalize it better because they are really small. As I said, sometimes smaller than the bevel of the needle. The syringes, we use 3 cc syringes. The best ones that can keep the foam for the longest time.
Thank you, Professor Lurie. For the sake of time, we'll go ahead with the next part. Actually, we'll take 2 minutes of silence to celebrate the birthday of 2 very beautiful ladies, Dr. Wasila Taha and Gabriella, whose birthday coincides with this week's webinar. So happy birthday to both of you. Wish you all the happy days to come. And here is a little recorded word from
Thank
Gabriella.
you very much for such kind and warm birthday greetings, and especially for this great opportunity of co-working with a wonderful group of people united by a common goal like education and science. Especially greetings for Dr. Wasila that's celebrating her birthday too. And muchas gracias.
The mic is yours, Dr. Wasila.
Oh, thank you, Dr. Rashad. What a nice surprise. Happy birthday, beautiful Gapi also. Special people are born in October, Gapi. Yeah? Thank you very much for this nice gesture. Thank you very much. You made my day, really. And I wish to all of you for the coming year, a blessed year, full of happiness, joy, success, prosperity, and good health. Thank you very much.
Very nice. And now I wish to, it's my honor to introduce Professor Hugo Navas, who's professor at Central University of Venezuela and president of Venezuela Society of Phlebology. He's our chairperson, our guest of honor from Latin America.
Thank you, Dr. Bichara. I want deeply thank to the organizers of this high-level academic activity, LATAF, especially you, Dr. Bichara, Dr. Bottini, Dr. Genesini, and Dr. Wasila Taha, on behalf of the Society of Phlebology from Venezuela, for having the deference to invite us to share these interesting presentations. I applaud the enormous effort and initiative to integrate our continents by exchanging knowledge and experience. I am very happy and proud to have today the privilege to listening the presentation of 2 Latin American friends, Dr. Zinke and Dr. Chunga, who despite their youth have extensive knowledge in the subject of sclerotherapy. They also had the blessing of having their own father as private master of sclerotherapy. So we can say that we have received today information collected for many years experience. I would not like to end my intervention without highlighting the importance of the ultrasound as support for the specialists who perform sclerotherapy, allowing to achieve therapeutic benefits comparable with other endovascular techniques. I have a question to Dr. Chunga. I always has a special, let me see, I write the question here. Okay. I have always the doubt in a case of reticular vein that drains a focus or telangiectasias, not that feed it. Which to inject first, telangiectasia or reticular vein, in order to avoid a matting.
Yes. The reticular vein. That's it. You have to start for the reticular vein. Even when the patient tells you, no, but I'd like you to erase my telangiectasia. No, you have, no. You are the doctor, you teach your patient that you have to close first the reticular vein because it's the feeder of the telangiectasia.
Thank you, Dr. Shunga. Thank you, everybody.
Thank you, Professor Hugo. We are really honored that you're with us today. And now we'll continue with our next speaker. Our next speaker is Carlos Simkin. He's president of Latin America Venous Forum and secretary of Argentine Society of Phlebology and Nephrology and secretary of Latin America at International Union of Angiology. Please go ahead, Professor Carlos Simkin. Share your screen, please, Carlos.
While I'm sharing the screen, I want to thank you all for the kind of invitation. Thank you very much for your time. Please let me know if you are seeing okay my screen. Is that okay? Okay, I'm going to talk about complication of foam sclerotherapy and how to avoid them. I do not have any conflict of interest. What is sclerotherapy? It's to target vein with chemical ablation of varicose veins by intradermal injection of a liquid or foam sclerosic drug. The treated vein may be intradermal, subcutaneous, or transfacial, working as perforator. As well, it can be located in malformations deeply or superficially. After a successful sclerotherapy in the long-term results, the vein is transformed into a fibrous core. This is a worldwide known process as sclerosis. What do we have to do to avoid the complications? Correct selection of the patient in order to avoid complications. Explain verbally and mostly write all the cases. The informed consent should be signed. A detailed clinical history regarding with allergy, thrombophilia, asthma, migraine with or without aura, SBT, DBT, and of course, right to left shunt known will know. Clinical examination is fundamental. And of course, choosing drugs and concentrations. Ultrasound examination, pre-procedure, intra and post-procedure are our eyes of the phlebologist, as my father always says. And of course, the discharge indication of the patient is fundamental to achieve good results. Where do we indicate it? We indicate it in all varicose veins, including AVM and venous malformation. Right here in the left print, you can see the indication and the grade of recommendation. What about the contraindication? The European guidelines of sclerotherapy contraindicate, absolute contraindication, allergy known to the sclerosant, DVT, pulmonary embolism, local infection in the area you are going to have sclerotherapy, long-lasting immobility confined to bed, and for foam sclerotherapy, in addition, no symptomatic right to left shunt, for example, symptomatic patent ovarian. What about the relative contraindication? Pregnancy, breastfeeding, severe peripheral arterial disease, poor general health, strong predisposition to allergy, high thrombophilic risk, and for foam sclerotherapy, neurological disturbances, including migraine and following previous foam sclerotherapy. How to avoid them? We have to make the optimal treatment approach is to match a given vessel diameter with the lowest concentration of sclerosant that can be expected to work, as well as to use the least volume possible for the desired effect. This is how we do it: a direct puncture of sclerosis. Check the blood in the needle. This is a clinical security sign. What about the complication? They can be classified as mild and severe. Mild is lipopenia, intolerance, immediately or delay, visual disturbances, and how the French school name it, travel oculitis, hematuria, liver colic. The severe ones are anaphylactic reaction, shock, DVT, pulmonary embolism, and of course, serious neurological event, transient ischemic attack, reversible ischemic neurologic deficit. What about the complication? What Cabesi and Parsi tells us? Foam sclerotherapy may result in drugs and gas-related complications. They can be localized or generalized. Generalized complications are anaphylactic reaction, DVT, SBT, stroke, tissue necrosis and ulcer when we check it in the arteriola, in the fat tissue, edema, nerve damage, and the cosmetic complications. They are local. They are the most frequent presentation as telangiectatic matting or pigmentation. Patent foramen ovale and other cardiopulmonary right to left shunts seems to play a role in the systemic gas-related complications. What happened in the US? SAFE. They give us SAFE with the ultrasound guide for anatomic closure. we can see signs of DVT, SVT. We can see direct the needle and the site of the puncture and the route that the foam is follow us, and we can see in live the venous spasm. But we can also perform directly the sclerotherapy, but we have to take account the blood in the needle. This is a clinical safety sign to avoid complications. Lipopenia or hypotension, when it happens, you have to lay down the patient if he's standing position, put it in translumbar position, put in an oxygen mask, and if the symptoms continue, inject 1.5 milligrams of adrenaline subcutaneously. And how to avoid it? In the next session, perform sclerotherapy with the patient laid down or change the sclerosing drugs. What about the intolerance? Intolerance can be immediately or delayed. The patient presents vomit, general discomfort, redness in the face, drum sensation, and of course, the treatment is to use another sclerosing drug or change to cryolasers. What about visual disturbances or troubles of iris? They present as scotomas. They always present secondary to the liberation of endothelin 1. They present as blurred vision, double vision, and they can appear after 15 to 20 minutes after the injection. How to avoid them? Use other sclerosing drug in the next session or decrease the amount. Use CO2 instead of ambient air with optimal ratio 4:1 liquid air. Lay down the patient for 10 minutes, and if you have the ability to perform laser, perform laser. Also, hepatic colic can be presented, observing the injection near the junction described by Perry Balaba and Robert Steamer. The treatment is suspend immediately the injection, and if it persists, use antispasmodic. Hematuria, chromic glycerin is secondary, very rare. Use another sclerosant or perform laser. What about the general severe anaphylactic reaction or shock? Dyspnea, cough, growing sensation, hypotension, low pulse, glottis edema, redness in the face, neck and body, nausea and vomit can occur also. The treatment is put oxygen mask, intravenous corticoid in bolus, 4 to 8 milligrams, adrenaline subcutaneous, very rare, very fast, and in case that the symptoms continue, call 911 immediately. It's an emergency. You have to have the emergency kit. Maybe you have to intube the trachea to avoid anaphylaxis. To avoid this, do not perform sclerotherapy in patients with asthma, antecedent of severe allergy, and perform laser. What about the DVT? 1 to 3% pulmonary embolism present. It's very rare. Patients with hypercoagulable state are at greater risk. Avoid to them. The risk with injection of large quantity of foam is sclerosant. Always inject 10 cc, no more than 12 cc. Combining sclerotherapy with a surgical procedure also increases the risk. Avoid this procedure in combining techniques. Ambulation after sclerotherapy is also important, having a high risk index of suspicious, and use ultrasound guided imaging as well as use of laboratory testing allows appropriate diagnostic and prefer for anticoagulation. What about the localized complication? They can be mild as hematoma, SVT, matting, hyperpigmentation, foot edema, and local allergy. And the severe complication local is ulcer, post-sclerotherapy, DVT, or intra-arterial injection. Intra-arterial injection is a catastrophic situation. This is a local allergy. Use painkiller, anti-allergic, diphenhydramine, and topic corticoid. And of course, contention. Always make a good contention for the patient. Hematoma. Use heparin gels, 1% gel. Reduce the calibers of the needles. Occlude immediately the puncture site, and compressions immediately after sclerotherapy. What about the SVT? A refined technique and expertise matter. Correct choice of the drug and concentration. Use lower concentration to target the varicose veins. Perform early embolectomy, no later than 7 to 15 days, no more. What about to minimize inflammation and matting risk? Match strength of a sclerosing solution to the vessel size. Use minimal concentration. Recognize increased strength of the foam solution. Minimize pressure of the injector. Make it slightly gentle. Minimum risk for vessel rupture by avoiding excessive injection pressure during the session treatment. Minimize volume per site. Reduce venous pressure into the site, eliminating reflux, and always have in mind to perform cryo-laser in the 1064 nanometer plus IPL as according to the guidelines. What about red matting? Typically can be treated with re-injection with a mild sclerosing solution. use enhanced visualization devices such as augmented reality, transillumination, and fine needles with 32 Gs is also can be avoided performing laser vascular lesions. Post-sclerotherapy hyperpigmentation can present with the deposition of dermal hemosiderin, red blood cell extravasation, or intrathecal post-inflammatory hyperpigmentation. The incidence range from 6 to 80% depending on the solution and concentration. Fortunately, it is rare after a year and also depends who is doing the procedure. Fitzpatrick skin darkness present greatest risk, so it is important to treat this patient with a mildest fluorescent solution to minimize the risk. Same principles applying as for mapping. Minimize risks for vessel rupture by avoiding excessive injection pressure and elevating the leg during the treatment. Consider to avoid post-sclerotherapy hyperpigmentation test areas. Thrombectomy should be done. Draining the intraluminal coagula is present after 2 or more weeks with 11 blade or 21C needle in order to drain gas coagula, and consider avoidance of treatment with iron and minocycline or switch laser in that cases. Local severe complication as tissue necrosis can occur. The first phase is an injury. During these phases can avoid this complication. 4 phases are occurring during the injury phase, occurring during the first injection, advanced the pale color in the skin and the popular formation in the intense pain. Then 8 post-hour injection, at least 15 days, painkillers, corticoid, and extension to the patient. Inject radially, as you can see here, when occurs lidocaine 1% or 2% dexamethasone. I give the massage zone radially to avoid this scar situation. What about the compression post-sclerotherapy? What tells the consensus? Telangiectasias, telangiectasis in reticular vein, reticular and small vein, truncal veins. All compression for 2 to 3 weeks, but most critical for the first 3 days. An adequate post-sclerotherapy compression avoid pain, edema, and future hyperpigmentations. So, as a conclusion, a good technique, adequate ultrasound imaging, general precaution of compliance, post-treatment instructions may be helped to avoid some of the adverse events. An appropriate and early intervention may minimize possible sequelae. High volume of sclerosal form have been attributed to local and distant thrombotic complication and should be avoided. Meticulous treatment technique and using a augmented reality transilluminator can reduce the incidence of side effects and prevention of the serious complication. And remember, foam sclerotherapy in training hand is an excellent technique with a low rate of complications. Thank you very much. I would like to invite you all for our Congress Buenos Aires 2021, and it's going to be held the UIP World General Council next year. Thank you very much for your time, and this is it.
Muchas gracias, Dr. Carlos Singh. We enjoyed your presentation. Thank you for pointing to the key elements to avoid complications. Now, Dr. Wasila, please introduce the panelists for the second speaker.
Yes, Dr. Rashad, but not before congratulate Dr. Simkin for the outstanding compiling of the complications of foam sclerotherapy. Congratulations, really, Carlos. Now, truly honored to introduce our compatriot, Professor Tariq Radwan. He is a convener Egypt exam for the Royal College of Surgeons, the MRCS examination from 2016 till present. And he is the editor-in-chief for the Egyptian Journal of Vascular and Endovascular Surgery from 2010 till present, chairman and co-founder of the Egyptian Vascular Club from 2004 until present, and member of the Military Academy. He is a member also of the lot of societies, the Vascular Society of Egypt, and so many international societies. Professor Tariq Radwan, we are really honored having you among us this night, and now the podium is yours.
Thank you very much, Professor Wasila. And I enjoyed both speakers, but I'm honored to discuss Dr. Simkin for his wonderful talk about the complications and how to avoid it. I would like to ask you, there is one question from the question and answer panel and one question from my side. So from the panel, one of the attendee asking about the pulmonary embolism, is the compression can prevent the occurrence of pulmonary embolism during foam sclerotherapy? Dr. Simkin, can you hear me?
Yes, I'm hearing you. You asked me if compression avoid the generation of pulmonary embolism. Is that right?
Yeah, this is a question from the question
I
and
think
answer
that
panel.
you can perform an excellent technique with the right concentration, with an excellent patient, but complications sometimes occur.
Yeah.
In a very low grade, but you can't avoid complications occur.
All right. Now, from my side, there's two questions. One of them is when you're injecting and communicating vein or a perforator vein, is any special precautions that you can avoid the escape of your foam to the deep veins? Any special precaution, or you use the same as elevating the leg or whatever?
First of all, you have to make a gentle and very slow injection. This is the first. Second, you have to, if you are treating a perforator vein, you do not puncture direct the perforator because you are almost 100%. You have to inject in the secondary network, secondary castles that drain into the perforator, the forearm, and elevate the leg. Then you perform the bandage and start to walk immediately.
Right, thank you. Now, I realize that both speakers of today mentioned the compression post-foam sclerotherapy, and they emphasized the use of compression. Now, all of us know that in the recent year, there's a lot of controversy in the literature, and I think there is one of the big literature randomized trial advertised in the European Journal of Vascular and Endovascular Surgery in January 2020 that compression and no compression has the same effect. Can I excuse Professor Wasil and Professor Rashad that we raise this to the all panelists to know their opinion, because I think there is a lot of controversy about this. If you would like Dr. Simkin or the first speaker or any of the panelists to comment, if you don't mind.
Dr. Tara, we cannot do this because we are
have a strict schedule, Dr. Tara. And
all
Dr.
right, I'm sorry.
But in the last slides of Dr. Simkin, he's beautifully highlighted this issue of the compression. He has a beautiful slide about the compression for the grades compression and how long he has to be on 2 days, at least the first 3 days. Totally agree with him. And there was an RCT for Claudine Hamel-Desnus also for the compression RCT. So it's important, like highlighted by Dr. Simkin. I'm so sorry, Dr. Tariq, I have to move to the next.
I understand, but what I want to raise to the attendee, that there's still a controversy. There's a big controversy about this in the literature. But I agree with you, all right? But I just want to raise it, and I think Professor Sergi want to comment on this. But it's thank you.
I think we have to move on. If you allow me, Dr. Osira, you have to move on to the next panelist so that we keep on time.
We have to excuse also Sergio. Sergio, it's okay for you? Okay. Now we are truly honored to introduce Professor Shuaib Padaria. Professor Padaria, he doesn't need any introduction. Of course, he is the famous cardio and thoracic and vascular surgeon. He is a famous phlebologist all over the world. He is settled in Mumbai in India, and he is the past president of the Venous Association of India, president of the 13th conference of this distinguished society last January, and it was an outstanding and top-notch conference with phenomenal hospitality. He's also the vice president of the Asian Venous Forum, the council member of the UIP, vice president of the International Union Angiology, and associate editor for so many distinguished journals. Professor Padaria, the podium is yours now.
First of all, thank you, Dr. Rashad and Dr. Vasila, for giving me the opportunity to share this lovely platform with so many of my international colleagues. A great, great meeting, great initiative. Carlos, that was a wonderful lecture, extremely comprehensive. I think you touched upon all the various complications of foam sclerotherapy. And rather than ask you any question, I would like to make two different comments here. First one is that, as you rightly pointed out, a lot of different sort of allergic reactions can occur in a patient following foam sclerotherapy, from very mild ones to a very severe one. Now, in the last 15 years of practice, learning from our experience as a cardiologist and having reactions in the cath lab when we have the time, when we are using angiographic dye which contained iodine. So what we do is that whenever we are planning foam sclerotherapy in a patient, at least 15 minutes before that, we will give every patient 100 milligrams intravenous hydrocortisone. As a result of which, we have seen that there is almost no allergic reaction. And if ever there is even a large anaphylactic reaction, it becomes very moderate because of the effect of the hydrocortisone, which I was given earlier. So that is comment number one. The second thing, in your slide, you mentioned that when you do foam sclerotherapy, you should not combine it with any other technique. I would like to differ on this particular aspect, because in the last 20 years of my treatment, I follow the principle of what is called the SICOT method of treatment. SICOT is single, complete, occlusive therapy of varicose veins in one single setting. Most of our patients do not want to come back again for a second repeat procedure. And in sclerotherapy, you know, especially when you're doing moderate to larger veins, there is a possibility you'll probably call them back for second or third procedures to achieve a complete closure. And therefore, for truncal veins, larger non-truncal veins which are straight, we will use any form of thermal ablation. For those significant moderate sized varicosities which are tortuous, we'll use ambulatory phlebectomy. And for the smaller varicosities, we will use foam sclerotherapy. We use all the three techniques at the same sitting. And I can tell you that in more than 95% of our patients, if one single procedure is enough. Having said that, I must also let you know that when we are talking of telangiectasia and spider veins and reticular veins, we will put this on a second sitting. We will not do it at the same sitting. So we will use sclerotherapy for moderate-sized varicose veins, which are non-truncal, ambulatory phlebectomy, and some form of thermal ablation as a single SICOT procedure for our treatment. Thank you once again, lovely lecture. And yours also, Dr. Chunga, a lovely presentation.
Thank you, Professor Kadaria.
Thank you. Very important comments indeed. Thank you. And now, Professor Luri, we have 3 minutes for Q&A from the box. Please.
Fantastic. I will try to combine several questions in one, if you allow. There was a question regarding the patent foraminal valley and migraine. So, Carlos, I think first question is, do you investigate the patients beforehand? And the second is, what you do if patients do have migraine? Do you look at the PFO in those patients? And thirdly, if the patient has known PFO, would you do something differently? You need to unmute yourself.
Carlos, you have to. Carlos, unmute yourself. Yeah.
May I respond? Can I respond?
Yeah.
Yes, sure, please.
In our cases, when we perform foam sclerotherapy, we try to avoid to perform if the patient has migraine or some kind of allergy. We perform in telangiectasias and reticular vein laser only, laser only. And regarding to the type of sclerosant that we use always in telangiectasia, we use liquid. We always perform liquid in telangiectasia. We do not perform elastic compression. And if the patient has another antecedent, we check with when echocardiography to searching for amenorrhea, but not for routine.
There also is a question of the role of NOAC in post-form pigmentation. And the other question is, in general, is there any role for anticoagulation and specifically NOAC's post-sclerotherapy?
Yes, good question. I like the question. The NOAC avoid the formation of pigmentation secondary because reduce the thrombus. So it's another weapon that we use to prevent post-therapy hyperpigmentation. But it's a complication that should be treated according to the international guidelines with NOAC.
I beg your pardon, Dr. Simkin, you can just switch the interpretation because the voice is not very clear. The button of interpretation. You are on the Spanish?
Interpretation off, please. Put
the translation.
Okay, we use the NOAC. It's a weapon to avoid post-sclerotherapy complication because reduce the hyperpigmentation, and according to the international guidelines, it's better if we use because reduce the symptoms of that localized complication and the hyperchromatic complication later. Yes, we use it.
Thank you. Thank you, Professor Lurie. We have to move on because we are a little bit late.
And now I think we have the time for the wrap up of both presentations. And I'm truly honored to introduce my long life associate, Dr. Rashad Bishara. And he asked me, Dr. Rashad Bishara asked me, no titles, no positions, no endeavors, no achievements. I don't know any long introduction, please, Wasila. And I do agree, and I did accept, because really kings never need any introduction. But just I wish to highlight something, Dr. Rashad, if you allow me. You are such a good mentor and good guru for your willingness to share your skills, your knowledge and expertise. And you are an excellent guy for the young fellows and role model for helping these fellows to achieve their goals. Thank you very much, Dr. Rashad, for being the one you are. And now the podium is yours to wrap up this night.
Thank you for the introduction, Dr. Wasila. I will just go on. Well, I will not repeat the two presentations because they were very comprehensive. I just decided to show what I think is the key slide in each presentation. For the presentation of Dr. Juan Chunga, I think this is the key slide. Know your weapon and know your enemy. That is, we don't need to use a cannon to kill a small insect. So the concentration and the volume and also the size of the needle must vary if we are treating telangiectasia as opposed to venous ulcers on the other extreme. As for the second presentation, complications of foam sclerotherapy and how to avoid them, of Dr. Carlos Simkin, there are a couple of key slides. I think this is one of them, that the optimal treatment approach to match a given vessel diameter is the lowest concentration that can be expected to work, as well as to use the least volume possible for the desired effect. I think this is the same message as for the first presentation. And then coming to the complications, he very nicely explained all the possible complications. But I would like to shed light on the rarest complication, anaphylactic reaction and shock. Anaphylactic reaction and shock is indeed very rare. It's 1 in 1,000 or even less. But if it happens and we are unprepared, it will cost the life of the patient. So we must be prepared. As he nicely said, we have to have all the gears to prevent death from anaphylactic shock if it happens. So I think this is the key. This is the key that I would like to highlight in his presentation. And now we come to the last and most beautiful part of this webinar, tips from the Grandmaster, and I'll ask Professor Sergio Genesini to introduce the Grandmaster.
And I will repeat myself again, quoting the paper about what we know and what we don't know, meaning that we all know Professor Tessari. I have the pleasure of knowing a fact that maybe somebody doesn't know, that he's really a wonderful person. So I really suggest you to get close to these giants like Professor Fedor and Professor Tessari and get to know also them in terms of their private attitudes.
We have a recorded presentation from Professor Tessari.
Good morning, everyone, and thank you, Dr. Rasha, for your invitation. This is my presentation. This is my disclosure. So, for the correct study of the varicose vein, it is necessary the study of saphenofemoral junction to understand of the distribution of reflux in chronic venous disease. So in 45% you have competence of terminal valve and of iliacal femoral valve. You have incompetence of terminal valve. The normal anatomic finding is this. When you have the normal condition of the low ovarian vein reflux, you have a left to right transuterine re-entry circuit. When you have an early pregnancy condition, left to right re-entry circuit, you have compression. In the late pregnancy, you have an interruption of the left to right re-entry condition. So in my experience, you have this casuistic. One pregnancy 20%, two pregnancy 45%, three pregnancy 65%, in the other 85%. This is the classification of Claude Franceschi, the pelvic varicocele, the pelvic varicose vein, the pelvic congestion syndrome, and the pelvic shunt. The point E, round ligament veins. This is, you have here varicography, and this is the case. This is in one family bilateral point E. This is the treatment in sclerotherapy and the treatment surgery treatment of P points. In sovrapubic region of spontaneous palma, this is my treatment. The first, the second, 30, 40. In the obturatorian vein, in this case, this is my treatment. In once 1 week, for 1, 2, 3, 4 treatment. This is the sciatic vein, 24% in my experience. This is the first treatment. And fibrovein 3%. In clitoridal vein origin, this is my treatment. In the point P, pudendal veins, this is the case, this is the origin, this is the origin, this is the other case. This is the Franceschi treatment, surgery treatment. I don't like this treatment, but after informed consent, I treat in this system. This is my production of foam. This is the 32 years pump to pregnancy. You have this. There's many reflux in Alcock canal. It's injection foam injection in Alcock canal. And the foam here. This is the other case. Alcock canal. This is the foam. Veint 3%. 4-5 cc. This is another case to pregnancy, 66 years. Any reflux in right in the vein. This is injection. It's another case. Alcock canal. Many reflux in this position. So, in 2 years, I treated 95 p-points, and the first phase is 2 of 3 sections, and in 22 cases, a second phase is of injection, were executed after 2-3 months. So, the excellent follow-up after 15 years, 88 complete. Toledal vein after 1 year. So this venous system is based on change in pressure, and its alteration produces hemodynamic change in a centrifugal and centripetal direction. The color duplex much for your attention.
Thank you, Sergio, for bringing Professor Tessari experience to us. It's indeed very interesting. Who would like to watch it again? So it's available on Veint Foundation website with kind permission from Professor Giannazzini. You'll also find a lot of very nice educational material. I'm sorry to have interrupted the discussion about compression, but we do have a complete webinar about compression on the 7th of November. This is going to be our last webinar, and you're all invited. And now we come to the last part of our webinar. Please, Dr. Wasila, introduce our guest of honor from Egypt.
Yes, Dr. Rashad, we're truly delighted to have among us our guest of honor this night, Professor Isam Al-Qadi. Professor Al-Qadi is the president of the Military Medical Council, chief of vascular surgery at Maadi Military Hospital, and he has been awarded the highest rank of prizes, the Presidential Award for Medical Military Service, and he was one of the founders of the Vascular Society of Egypt and examiner in the Royal College of Surgeons of England. Actually, he is the college advisor for Egypt. He's a member of the scientific board for the fellowship, the Egyptian Fellowship for Vascular Surgery. We are truly honored having you among us, Professor Isam Al-Qadi, this night. And now the podium is yours to deliver your words as our closing ceremony for this night. Professor Al-Qadi, please.
Thank you very much for this honor appreciation from all of you. Actually, I am very pleased to be with you and to be the guest of honor of this very, very beautiful scientific occasion. And I am very grateful for Professor Dr. Rashad and Professor Dr. Wasila Taha to invite me to be the guest of honor of this very good scientific. I quite enjoyed actually the meeting. I quite enjoyed the two excellent lectures from both of the very eminent Venus professors, and I am quite enjoyed the discussion, and it is a great honor for me to be the guest of honor of this very good and successful scientific meeting. Thank you very much.
Thank you, Professor Raki. The honor is ours. We're really honored.
Thank you very much.
We come to the last minute of our presentation. We would like to thank once again our sponsors, Servier Daphnome, Medtronic, Biolitech, ECS, Medi, and ProMed, for their unconditional sponsorship, without which this could not have been possible. And I would like to remind you that next Saturday, we do not have our usual webinar because this is replaced by the American Vein and Lymphatic Society meeting, which is online, and you're all invited to attend. Our next webinar is going to be on the 24th of October, in 2 weeks from now, and is going to be about the deep system. Thank you, and bye-bye.
Thank you. Bye.
Bye-bye.
Bye, everyone.
Bye-bye.
Thank you.
Thank you for the invitation.
Bye-bye, everybody. Bye.
Bye. Thank you very much. Great meeting.
Thank you,
Thank you.
Fedor. Thank you,
Happy
Rashad,
birthday,
Wasila, and all of
Thank you very much. Thank you.
Great webinar.
Thank you.
Stay in touch.
Sure.
Bye. Thank you.
Bye-bye. Bye-bye.
Bye-bye.
Have a nice weekend. Bye-bye.
You too.
Bye-bye.
Bye.
Good night.
Okay.